Is this mic live? I talk loudly. It's hard to tell if I have a mic on or not. I want to welcome everybody to our instructional course, Ketoprosthesis Surgery, Essentials for the Beginning and Experienced Surgeon. With my present company excluded, we have an excellent faculty today, including Dr. Samar Basak, Dr. Gina Mascarenas, Dr. Gerald Schultz, Dr. Kresh Moskati, Dr. Srinivas Rao, and Dr. Radhika Tandon. So it's a who's who of ketoprosthesis surgeons here in India. And Dr. Schultz is going to lead it off with a brief overview of ketoprostheses.
Good morning, I'm Dr. Schultz, and we all thank you for coming here this morning. This will be good nourishment for you, and you'll really leave with a lot of practical knowledge. This is the Boston Ketoprosthesis, which will be the highlight of this show. And of course, we have to talk about financial interests in K-Pros. I really don't have any, but there has been some type of sponsorship. Now, why do we use a keratoprosthesis? Well, there's about 10 million blind people in the world from corneal disease, and there is a lack of donor material, and also there's many people in countries that even if the cornea is available, they don't have the funds to provide for it. The interesting thing is that at one time it was considered to be a procedure of last resort, no longer. And as you'll see in this presentation, it can be the procedure of first resort because of improvement of designs, materials, antibiotics, etc., etc. So why are you involved? Well, most of you are general ophthalmologists, but you do have patients that have corneal disease. Some of them already have had corneal transplants. So you will be the one to select appropriate candidates and choose the appropriate surgeon who can take care of your patient with the appropriate procedure. And of course you'll be involved in the post-operative care and when to refer back to the operating surgeon if necessary. Here's the history. Very interesting. Pierre de Quangze was the first to perform a ketoprosthesis using a glass plate. Needless to say, his patient really didn't do well. Houser was the first one to have a successful transplant, and that was in the mid-1800s, and it lasted for about 3 months. And then there were other experimental studies. Now, this is the operation performed by Pierre de Quangze. Very crude, whole cornea, 2 sclera, and sutured it in. Look at those instruments. It's amazing the patient survived. I'm going to go through different classifications of the K-Pros. First, we'll start with the location. Epicorneal means it's on top of the patient's own cornea, covered with a tissue which we'll go into, and these are the various doctors in the years that they created their implants. The next is the lamellar, intrastromal. The order of one is still being used. Alpha Core is one that's been approved in the United States. There's the collar stud, which the Dolman Boston lens is the most popular, although Jan Warst and Daljit Singh may object to that. The nut and bolt, interesting, we'll talk about that, where the tube goes into the eye and it's screwed from behind. And of course we talked about the total cornea from Pierre de Quangze. Epicorneal, again, the haptic is on top. Here's the tube. It's usually a 2-stage procedure where it's implanted in the patient for about 2-3 months and then placed on the patient, and here's usually buccal mucosa on top. And these are the various types. Strampelli, the osteodonto ketoprosthesis is used, and of course the Pintucci that Dr. Mosky is going to be talking about in a few minutes. Here's the lamella type. The Fyodorov and the Alpha Core are the most popular, where the patient's own cornea is laminated, an opening is made posteriorly, the tube is put down, and this is after it's been integrated for about 2-3 months in the lower lid or cheek, and mucosa is placed on top. Here's various types of Fyodorov intralamella, different designs, different materials, but it's still being used. Most of them were designed by Moroz, who we met a year and a half ago in Moscow. The nut and bolt, very interesting type. To put this in, you actually made almost 180-degree limbal incision, put the tube down, the optic cylinder, and actually screwed the bolt from behind. It's not really being used today. The collar stud is the Dolman, the most popular, and that one, it's you need a donor cornea. It's usually a one-stage procedure, and you'll find out soon from Dr. Aldavi how that works. But the interesting one is the Worst Singh. I call that a belt and suspenders, where he has a suture attached to the equator. So not only is it the collar button, one type of anchorage, but also the sutures. This is how it looks with these wires coming out, and it's tapered, and indeed it almost looks like a champagne cork. Now we'll talk about the materials, integrated that I alluded to, and non-integrated. With the integrated, it allows biointegration of the connective tissue and vessels for the supporting haptics, and there are different types, lots of them. Dacron, nylon, bone, tooth has been used, and it's a two-stage procedure where I told you that it has to be implanted into the patient, and here's integration within a meshwork. This is how it goes. Here's the osteodonto type, mucosa on top, and the patient's cornea. For the non-integrated, which the most popular is the Boston Dolman, that's a one-stage procedure. It does require removal of the patient's lens, but not at the iris, as the integrated ones require both the patient's crystalline lens and the iris. Covering tissue is various sclera, etc., oral mucosa, which is employed to cover it, and it's probably the best because it's more vascularized and has a faster turnover and some barrier to microorganisms. Now, these are the various skirts and haptics, and the people's names attached to it. You can see all types. The interesting one is the Pollock that was used back in 1980. The mesh, various types are being used, and the ceramic that I mentioned, Pollock, and the Strampelli, you'll see that in a minute. Here, look how thick this is. This is the ceramic of Pollock, but it's fenestrated holes. This is Pintucci that Dr. Mosky is going to discuss later, Dacron mesh, and of course the optical cylinder. Now, there are nothing is free, and there are some adverse effects. It does lower the natural defenses of the patient, and it does enhance antibiotic resistance. Of course, we could get infection, expulsion, leakage of aqueous that we're always aware of. This is the alpha core. Methyl methacrylate, same material for the central optic, and the skirt is porous, same material. And you have to have adequate tear production. It's lamella, and it is put in the patient cornea pocket. In this case, it's put in the cornea for integration for 2 months before the opening is made in the covering tissue. Here's the osteodontokeratoprosthesis. And again, the dentine is clipped off. No, the dentine is the porous part. The crown part is clipped off. And it must be the patient's eye tooth, huh? I don't know. Here, it's put in there, and it's integrated in the cheek or the lower lid. Oral mucosa is put on at the first stage, and then the prosthesis is placed a couple of months later, and an opening is made in the mucosa. And this is the Strampelli. It was modified by Fasanella, who left the periosteum on, and it's been used a couple of times in the United States at Bascom Palmer. It's investigational, and it's being used more in Europe. It was modified by Hull and increased the visual field of the opening. Now, the one that's being used most is the Dolman. Dr. Aldavi will be discussing this, but we have the optical cylinder, the back plate, and the clip. This is made of PMMA or titanium, and it's fenestrated with the holes. 2 sizes, the smaller, 7 millimeters, the larger, about 8.5. Again, since we're recreating the corneal curvature, it's 43 to 44 diopters of curvature for the phakic, well, I wouldn't say phakic, pseudo-phakic eyes, but for the aphakic eyes, it depends upon the axial length. And here are 2 styles. This is 1, this is 2, this goes through the lid for the dry eyes. There's 1, here's a post-op, you can see the fenestrated holes and here's type 2, that goes through the lid. Type 1 has the advantages. It's really a short learning curve for corneal surgeons and therefore reduced complications, but you do need good tear production and blink function. Type 2, severe dry eye patients, but steep learning curve. And the problem is, patient moves the eye, but the lid is keeping it from moving. So you're getting more problems with it, and you can see how unsightly it is. All this was written up in the current issue, Archives of Ophthalmology, the January issue, and in this case it came from Bascom Palmer, and it talked about epithelial downgrowth that caused some vitreous retraction, internal limiting membrane. They did a vitrectomy, analyzed it, indeed it was epithelial tissue. And here's the article. Being used as a first-line surgery in pediatrics. Dr. Akpak, who is here at the meeting, I saw her listed. Is she here in the audience? No? Yes, it's being used for pediatric cataracts, and apparently there's a better response for children even under the age of 1. And here's some bilateral cases that were done. Aquavella, she trained with Aquavella, who was the first one to do pediatric, and she's doing it at Wilmot. So, these are reasons why they could fail, because of glaucoma, macular degeneration, creation of a membrane, retroprosthetic membrane that could be treated, and infection, retinal detachment, some of which are here in India could be fungal infections. What's happening in the future? We want to get non-penetrating implants, just like the deep lamella keratoplasties down to Descemet's, but don't invade the eye. That's being worked on at Bascom Palmer. And I want to thank you for your attention.